Our next speaker is Dr. Farhaan Vahidy. Dr. Vahidy serves as Associate Director of the Center for Outcomes Research, the CORE, at Houston Methodist. He holds the inaugural Conaway Family Centennial Endowed Directorship in Quality and Outcomes. Dr. Vahidy is also serving as the CORE
I can't hear Dr. Kent.
Division Chief of Population Health Science and Health Services Research. He also holds additional appointment of Associate Professor at the Neurological Institute at Houston Methodist. As Associate Director and Division Chief, Dr. Vahidy leads the development of learning healthcare system models. He utilizes artificial intelligence and machine learning for a rapid integration of scientifically robust evidence into healthcare practice. He has expertise in outcomes research applied to stroke and cerebral vascular diseases, and he's particularly interested in intracerebral hemorrhage. Prior to this, Dr. Vahidy was an Associate Professor of Neurology at the McGovern Medical School at UT Houston. At UT Houston, he directed the Data Management and Analysis Core and the Division of Population Health and Health Services Research. So the title of his talk is Predicting Bad Outcomes Before They Occur in a Learning Healthcare System. Dr. Vahidy?
Thank you so much, Dr. Kent. Can you guys see the slides or hear me well?
We can see you. No slides yet.
No slides yet. Okay, let's see. How about now?
Yes.
Okay, so we're good to go?
Good to go.
All right. Well, thank you so much for the introduction, and thank you for everyone who is joining us this afternoon. As Dr. Kent introduced, my topic for the CME event is predicting bad stroke outcomes in our learning healthcare system. And let's just start off by, let me see if, perfect. Let's just start off by highlighting some of the CME objectives. So we will, in the next 15 minutes or so, try to understand the overall digitization challenges for the healthcare industry, hopefully be able to articulate concept and components of a learning healthcare system, and particularly place the healthcare digitization in the context of a learning healthcare system. Then I would try to share a case study for secondary stroke prevention implementation in a learning healthcare context, and wrap up the presentation by communicating potential avenues for stroke-centered predictive analytics. So we know, all of us in this audience, that healthcare is on a precipice of a digital revolution, and has been for a certain number of years. As an industry, the healthcare tends to rank really low on what is called a digital quotient. And what digital quotient is defined by is three primary things. It's data asset, it's data skills, and it's data utilization. Now, there is no dearth of data asset as far as healthcare is concerned. And as I'm trying to show here by this graphic, I don't know if my cursor is here or not, there are several sources of healthcare data, starting from healthcare encounter data and claims data to biometric and patient-reported outcomes, consumer and socioeconomic data, and omics data. However, most healthcare asset utilization is kind of stuck in this left lower quadrant, and we have not really explored this big arc of data that is available, and hence there is a poor utilization to asset ratio. And why is this utilization so low? Well, there are several reasons for it, but the important ones that come to mind are healthcare data generally exists in silos. These could be inter-institutional or cross-institutional silos. There are resource constraints. There is a slight degree of maldistribution between the skills to utilize these data and where those skills are. The healthcare data is generally governed, owned by healthcare organizations, by hospitals and healthcare systems, but the skill is more centered in healthcare industry. And then, of course, there are privacy and confidentiality concerns. So what is the solution? Well, one way to think about a solution is to think about enabling a healthcare learning system, a learning healthcare system. And there are several ways in which a learning healthcare system has been defined. But there are certain elements of that definition that would be common across any given explanation of what a learning healthcare system is. So a learning healthcare system is one which is designed to generate and apply best evidence for collaborative healthcare choices for patients and providers to provide a process of discovery as a natural outgrowth of patient care, and to ensure that we have innovation, quality, safety, and value in healthcare centered in this process. Building a little bit more upon that idea, the LHC focus areas would be of fundamental science and informatics that is needed to generate evidence. Then, as I mentioned, it has to be patient and clinician partnership based, so that at the end of the day, the patients are engaged and empowered. It has to incentivize values, both value as far as healthcare is concerned and values as far as institutional values are concerned. For example, Houston Methodist's I Care values. And it has to have a leadership instilled culture of learning and supportive system competencies. Another important aspect to, I think, share as far as a learning healthcare system is concerned, that a learning healthcare system is a socio-technical construct. And let me take a minute to elaborate upon that a bit. All of us are relatively familiar with the data, evidence, and the feedback cycle. So data are generated, they are analyzed, findings are interpreted, they are fed back into the system that brings about a change, and then we continue to evaluate and monitor that change so that the whole process is kind of reinformed. However, this model does not exist in isolation. As a matter of fact, it exists in a socio-technical construct. The technical part is so-called the afferent limb, which deals with the data. So it's the technological advancement in terms of electronic medical records, big data, computing power, AI, machine learning, and other advanced technologies that enable us to handle these big amounts of data and assimilate them so that evidence can be produced. But there is an equally important, if not more important, efferent limb, which helps with taking these findings and implementing these findings across the system and learning from these findings, which is a very different skill set and includes behavioral psychology, communication sciences, dissemination and implementation research, economics, policy, and organizational theory. Another important feature to think about when we think about how the data progresses through an organization is a bottom-up model or a top-down model that is usually seen in organizations that are implementing this kind of process. So classically, we look at this model as a pyramid where data are captured as the base of the process. It is processed to create information. Information is processed to create knowledge, and eventually that leads to creation of wisdom. And if we look at these four stages across an organization, we can think of a parallel process of systematic decision-making that is happening. There is operational, tactical, strategic, and systematic levels for this decision-making. However, what we have experienced and what we have thought about is that enabling this top-down or bottom-up approach can sometimes create a lot of distance between the operational level thinking and the systematic thinking, or the tactical thinking and the systematic thinking. So it is probably more important to think of a learning healthcare system as a non-hierarchical model and an adaptive system in which instead of steps across a pyramid, we actually have loops. So there is a data loop that involves planning and implementation of processes and handling of big data. And big data, as we know, is characterized by its volume, velocity, veracity, and variety. And then this data loop feeds into an information loop, which deals with development of tools and platforms that provide efficient, contextually relevant, and readily accessible information to stakeholders. The information loop then feeds into a knowledge loop, which enables a continuous review and generation of information, which is actionable knowledge, and implementation of this knowledge and monitoring its impact. Now, one thing is missing that I showed in my last slide, which is the wisdom. And where does the wisdom go as far as this non-hierarchical model is concerned? Well, we believe that the wisdom is central, and the wisdom does not reside at the top. And it's a collective wisdom that is generated from the process, and it's not isolated. And it should rather permeate through the organization to inform practices and policies and establish the organizational mission and culture. Well, I think by now I have talked in a slightly abstract sense, and I would, through the next part of my presentation, try to talk about a specific example and relate to the concepts that I have talked about in a more kind of practical way. So I will now shift my focus towards our case studies. And the topic of my presentation, if you remember, was predicting bad outcomes. I think out of all the outcomes, and you all have heard about several predictive models, several outcomes that we have talked about throughout the day, but of all the outcomes that we are interested in as cerebrovascular disease physicians or researchers, I think few would argue that the worst outcome is having a stroke in the first place at the population level. So if we can avoid that outcome, it would be fantastic. But I think what is equally more important, and probably some would argue even more important than primary prevention, is secondary stroke prevention. And why do I say that? I say that because secondary stroke occurs in our patients that we have taken care of. And by we, I mean the larger stroke community. And these are the patients who have had their first contact, usually, with a healthcare system. So not really focusing on secondary stroke prevention is akin to us dropping the ball on being able to prevent a really poor outcome. Now, we know that the minor stroke or transient ischemic attack is a harbinger of poor outcomes. And there's just a lot of increased risk in minor stroke and TIA patients to get a secondary stroke, particularly during the first year or even the first 90 days of their initial event. And the evidence around rapid and aggressive secondary stroke prevention in this population is not novel. I'm presenting two studies here that date back about 13 years or so, and which have clearly indicated how timely and targeted control of timely and targeted management for secondary stroke prevention is efficient. The first is a UK-based prospective observational study in which, during the phase 1, comprised of an appointment-based care for TIA patients versus a phase 2, during which immediate care was initiated through express study clinics. And one can really appreciate over here the risk reduction in phase 2 as compared to phase 1 in the risk of secondary stroke among TIA and minor stroke patients. During the same time frame, another study from France demonstrated that 24/7 round-the-clock TIA management clinics ended up reducing the 90-day stroke rate to about 1.25%, whereas the predicted stroke risk in this population by ABCD method was about almost 6%. Now, fast forward about 10, 12, or 13 years, it seems that we have made some progress as far as risk reduction is concerned for TIA. These studies demonstrate that there is about a 6.5% risk during the first year and another 6.5% during the second to the fifth years. But we also know that sites that participate in quality of care registries tend to do better as far as provision of quality of care is concerned. And when we look across more broader population-based data, it seems that we have not made that much of progress. So this study, which was very recently published last year, demonstrate that the early gains that have been made in secondary stroke prevention may have been stifled or not carried forward. Therefore, studies like this are very important. And this is a classical example of how a learning healthcare system-based approach can be taken to design, implement, and monitor quality of care for prevention of secondary stroke. This was published last year, and we got the opportunity to editorialize this for the journal. And it is from our VA system, not our VA system, it's from VA system from colleagues in Indiana. And what they did is that they developed a secondary stroke prevention intervention, which was implemented across 6 sites. These were prevent sites. And then they took 36 other matched control sites. And over a course of 1 year implementation, they had a without fail rate, which really meant that patients across the various metrics of secondary stroke prevention met 100% of those metrics. And that without fail rate improved by 17% in the intervention sites as compared to only 3% in the control sites. So this was a big kind of treatment effect. What is important to realize, and this is a quick data from the paper, what was being monitored is anticoagulation for AFib, antithrombotic use, receiving brain imaging, carotid artery imaging, statin therapy, hypertension control, neurological consultation, and a combination of all these as a without fail rate. The blue shows the absolute difference before and after the implementation in the control sites, and the red shows the same absolute difference in the intervention sites. One can see these differences quite remarkably different from here. But I think what is even more important to appreciate is the amount of planning and systematic effort that goes into designing and implementing a study like this. And this takes us to 3 different studies that have been published by the same group in 2017, 2 of them in 2017, and then 1 in 2019, which demonstrate the amount of work that went behind in creating this learning healthcare system, is starting from validation of electronic medical records to understanding the gaps in secondary stroke prevention across the VA system, and then designing and implementing the intervention. And this is a detailed graphic that demonstrates some of the gaps that were identified and how they were circumvented in the intervention for the PREVENT trial. So there were knowledge gaps, and for which professional education materials were developed and distributed. There was lack of performance data for which a quality of care reporting system was established. There was a high degree of uncertainty around a QI process for which a virtual QI collaborative was established. There was inadequate care coordination, which led to development of clinical programs across settings and across the specialties. And finally, there were IT barriers for which electronic health record tools were developed. And this is an example of the study hub that was developed, which provided live information at the patient level, live information at the facility level, along with comparative metrics and prior performance, and also suggested targets for action. With that, I come to my second last slide, in which I'm just going to try to summarize all the areas in stroke research where predictive analytics can be applied. And again, many speakers before me have talked about these areas, including our keynote talk. But one can imagine the whole spectrum of disease, and we can apply these predictive methods for risk prediction, that is for primary and secondary stroke or stroke subtypes, diagnostic predictions, and we have heard about that today, including imaging and biomarkers, predicting suitability of level of treatment for early triage decisions, potential value and outcomes of intervention, be it intraarterial or intravenous thrombolysis or thrombectomy, surgical interventions or rehabilitation, predicting stroke evolution during the acute phase, either for ischemic stroke or for hemorrhagic stroke, and predicting potential complications, maybe neurological and non-neurological, leading to neurological worsening. And then, of course, finally predicting outcomes, which could be short-term outcomes versus long-term outcomes, functional, cognitive, quality of life outcomes, and domain-specific outcomes. So with that, let's just quickly revisit and summarize what we have talked about. We talked about digitization challenges for healthcare industry. I attempted to share with you that there's a high untapped data asset. However, there is poor utilization of that asset, and there are several reasons for that. We talked about some of the concept and components of a learning healthcare system. It's a system that is designed to generate and apply best evidence as a natural outgrowth of clinical care. It undergoes continuous evaluation and is patient and physician-centered. It is a socio-technical system. It has technical components and organizational theory. And it's better to avoid a top-down approach, instead having a non-hierarchical approach. We looked at one example from a large VA system of how LHC concepts was applied for a secondary stroke prevention program. And then I very briefly tried to summarize all the avenues that they are there in the future for application of predictive analytics. With that, I come to the end of my presentation. I'm sorry if I ran over time a bit, but I'm open to questions.
Okay, well, thank you very much. That was an excellent presentation. Lots of information for us. Much of it might be new for many of us. I have kind of a basic question. So with the LHC concept and its implementation, let's take your TIA example. There's not 100% agreement on how one should approach, for example, an acute TIA. So how do those uncertainties get implemented into the LHC model?
That's an excellent question. So LHC model is really, can be broadly, I guess, looked at a platform that is going to promote discovery and a platform that is going to promote implementation. The example that I shared, of course, fell more into the implementation context. Right. So yes, we have a lot of uncertainty, well, considerable amount of uncertainty about how TIA should be best managed or even defined probably. Mm-hmm. But there are some class 1 level A evidence things that we know work. And LHC model can look at that and enhance the implementation of that. But the LHC model will also support discovery. So at the same time, through this bioinformatics pipeline, the data that are being collected on a continuous basis, alongside regular care provision, can be used and put through that.
He froze. He froze. Okay, it looks like maybe we have a little technical problem with freezing. I think we're about out of time, and so listen. I want to thank Dr. Vahidy, even if he can't hear us. Thank our other speakers, Dr. Garg, Dr. Ruiz. I appreciate very much. I think we've learned a lot in terms of prevention, both of disease as well as of complications. So please stand by. Your next session will come up. It's on recovery. Will be moderated by Dr. Caldis. And thank you very much.